the end, we have exciting merch.
Edible merch.
Still merch.
All right, everyone, thank you very much for being here. You know, I know it's 3 o'clock on a Friday, and we'll try to get this along as fast as we can. So my name is Mel. Thank you very much for the introduction from Dr. Amela and Dr. Hutchison for us event today.
And I'm Jenny.
So today we're going to be talking a little bit more on not so much the research, although we will give you a short brief introduction, a brief overview of what we do in our lab, but we're going to be talking about lessons from translation. So trying to move this research, especially in women's health technologies, beyond the lab. So what do we want to do when we want to get money, when we want to commercialize our system? And as we saw today, we saw a lot of great in-lab research. Thank you to our speaker and everybody who presented. Now those are all inside this building, inside another building. How do we get this product into the hands of the people that we're actually designing this for? We all started with a grand challenge. Now how do we actually get there?
So I want to start not with technology and not with optics, but with the number 1 in 8. 1 in every 8 births worldwide is premature. Let that sit for a minute. We're not talking about a rare disease, a corner case, or an edge of distribution. We're talking about roughly 15 million babies born each year before their bodies are ready, before their lungs have fully developed, before their brains have completed critical developmental windows, before their immune systems are equipped to handle the world outside the womb. 15 million families facing a crisis that they were not really predicted and prepared for. Preterm birth is the leading cause of death among children under 5 worldwide. Approximately 1 million newborns die each year from preterm complications alone. Not from infection, not from accidents, not from being born too early. And for the survivors, the burden is substantial. Respiratory distress syndrome, intraventricular hemorrhage, retinopathy, neurodevelopmental issues, hearing loss. A NICU stay for a very premature infant can run into hundreds of thousands of dollars, and the emotional, physical, and economic cost of family is immeasurable. Now look at the third number, 0. There is 0 objective or early warning tools in the standard clinical care. That is the clinical gap. In 2026, with everything we know about biology and imaging and signal processing, we do not have a single quantitative objective diagnostic tool that can routinely be used to predict preterm birth before symptoms appear. To understand our approach, you need to understand what's happening biologically. During pregnancy, the cervix undergoes a dramatic transformation, a process called remodeling in early gestation. The extracellular matrix, particularly the collagen component, is tightly packed and well organized. This organization gives the cervix its mechanical integrity, its stiffness, its ability to hold a pregnancy. As the gestation progresses, that organization breaks down and collagen fibers lose their anisotropic organization. The extracellular matrix becomes disorganized and the cervical stiffness drops, first gradually, then rapidly, as the cervix ripens and dilates ahead of delivery. In a normal term pregnancy, this is exactly what should happen, on schedule. In preterm birth, it happens too quickly. And critically, the structural disorganization precedes the visible or palpable changes by weeks. If we can detect it optically, we have a window for intervention. This is the translational vision of the medical photonics lab. On the left, you see the tools of our science: research microscopes, polarimetric imaging, schematics, histological sections of cervical tissue, mouse models, multimodal data stacks. On the right, you see where we're going: the clinical colposcopes, point-of-care handheld devices, examining rooms for patients. The arrow in the middle is what this talk is about. Not just the science that gets us here, but the process of moving across the gap. So what's our scientific approach? Collagen is inherently an anisotropic material. Its fibrous organization structure interacts with polarized light in a predictable way. Specifically, it exhibits linear birefringence. And when collagen is well organized, as in early pregnancy, that birefringent signal is strong and coherent. When it's disorganized, the signal changes, and the Mueller matrix imaging exploits this property with extraordinary sensitivity. No existing clinical diagnostic tool can do this, and no current device reliably predicts preterm birth. That's the opportunity. Our research follows the deliberate 3-stage pipeline. We begin with animal models, specifically the marine pregnancy model, which compresses the full gestation time period into regular, roughly 19 days, and allows us to collect tissue at precisely defined time points. Cervical cross-sections are harvested, sectioned, and mounted for imaging across full gestational span from day 0 through delivery, and those tissue sections feed our benchtop optical systems where we build the fundamental knowledge base. At the benchtop stage, we use 3 complementary imaging modalities. The first is reflectance Mueller matrix polarimetry. The second is confocal Mueller matrix polarimetry, which adds depth sectioning capabilities. And the third is polarization resolved second harmonic generation, which provides label-free molecule-specific imaging of fibrillar collagen with submicron resolution. Together, these modalities give us a multi-scale, multi-contrast picture of cervical extracellular matrix architecture across gestational time. The system that validates our method is a large-scale benchtop system built in-house called the SAM. This platform integrates a variety of optical components powered by a femtosecond laser and enables depth-resolved imaging through other mechanical components, altogether giving high-resolution images and provides validation for our polarization-based methods. This slide shows what the biological signal actually looks like. On the left is a cervical cross-section from early gestation, day 6. The color shows collagen fiber orientated circumferentially around the stroma. And on the right is day 18, late gestation, just before term delivery. The same type of tissue, the same imaging modality, the same color encoding, but the organization is gone. This collagen organization is directly linked to the cervix compliance and structural strength. This is the TRIM, or the transmission reflectance imaging Mueller matrix microscope. As we have already seen, the polarization imaging allows us to visualize and quantify the collagen organization in the cervical tissue. TRIM is our benchtop implementation of that approach, a simplified microscope system designed specifically to obtain polarization images of the cervix across our tissue sample library. This is the system that powers our large-scale tissue pipeline, and it represents the conceptual foundation for the clinical device we are working towards.
All right, so now that we've gone through these benchtop optics as well as the animal models, I want you to finally focus on the clinical stage of our work. So the fundamentals that is driving this mechanism is this polarized contrast when it interacts with biological tissue. This is an intrinsic property of the tissue. It doesn't matter if we're taking samples on a slide or we're using it in the clinic. So the clinical system can do the same thing. So first, we have the Mueller colposcope. So the colposcope is already part of the clinical existing routine exam for cervical examination. So by adding the capabilities of polarimetric imaging, we're able to capture this fiber orientation around the cervix in healthy non-pregnant women as well as pregnant women to look at the collagen alignment around the cervix. So the image, that's what this image here shows. Now, now that we understand that this actually works in the clinic, what we want to do is develop a handheld form factor that is designed for imaging at the point of care, keeping in mind that we can take this to low resource settings, community clinics, and eventually at-home monitoring, especially with telehealth in mind. So this device is not required an infrastructure of a clinic, of a colposcope, and all the accompanying tools, but more importantly, it's portable and it's speculum-free. So this is what the requirements that drove the design of this new device that we have in the print. So the print is just an overall, it's a compact packaging of all this small electronics and a custom housing with its key factors. So what it has is a microcontroller inside, polarized camera, laser diodes that are enabling this polarized imaging in a handheld form factor, as well as accompanied by a disposable sheath that provides a hygiene barrier for the examination with each use and each patient. So this by no means is the exact product that we'll have in 1 year or 2 years, but it's the product that we're going with to market that is viable as we move on towards our commercialization process. So meanwhile, we'll still continue testing and we'll still make the improvements that's necessary for this to function properly in the clinic and for everyone. So now we're moving towards the commercialization aspect of the story. Thank you for bearing with me. You've seen some of the stuff before, but I want to touch on IP and intellectual property first. So IP is what bridges the gap between academic research and commercial translation. This is what protects academic research, your work in the lab, from being scooped out from by large companies that can do stuff faster, better, and cheaper before you even hit the ground running. So in our lab, we have a couple patents that have already been awarded around our polarimetric imaging system, as well as the analytical method and other works that we have, as well as patent disclosures that are filed with FIU through the Tech Transfer Office that protect the ongoing work that we have still in development. So I really want to highlight here is that it's very common to file these patent disclosures. And you don't really want to do it as you're about to commercialize, but you want to do this every step of the way, and FIU has the tools to make that happen for you. So this is just a simplified process of what FIU can really do for you. So it's a 5-step process to be able to get a patent and release it to a company or your own startup in the process, whatever you may decide to do. So with the invention disclosure form with the Tech Transfer Office, you can file that at any stage of your development, not even if you don't have a complete product. So that's the first thing you want to do. Second, you'll talk to the office, they'll gather all the required documents, and then you'll begin to file these patents. Third, they can file a provisional or a non-provisional patent for you. And what you want to know is that the cost of filing these patents can rise above $10,000. Now, they pay this for you. It's not coming out of your pocket. However, the caveat is that because you're using university resources to file these patents and develop this product, FIU does own 100% of your work. However, all the revenue is split depending on the negotiations with the institute and the company. So here is a typical roadmap to translation from your research to a commercial product. So first, everybody knows we're starting with innovation, right? An idea, a discovery, or a prototype. Then you would consider going through what's called the I-Corps process, which is a consumer discovery program that's federally funded. And then you can create a startup or work with the company to file for additional funding to work on the next R&D phase of your product through SBIR, phase 1, phase 2, STTR. And then hopefully once you're past that phase, you'll have enough funding as you're working with attracting investors and venture capitalists to take your viable product into the market. And now that you've seen our innovation, I'd like to go deeper into this I-Corps process, which, if you know the I-Corps, you know how awesome it was, but some of you may not be introduced to this, so I'd like to go through that process. It's a little bit different from any technical presentation. So what is the I-Corps? You may have heard the word thrown around. The I-Corps stands for NSF's Innovation Corps. It's a federally funded program that takes federally funded research from universities and takes them into a commercial product or service. Now, the I-Corps itself is designed for customer discovery. I want to be specific, it's customer discovery. So you're really trying to find what your product is actually serving. So you want to be talking to people, and the key idea that they apply is get out of the building. Some engineers, we're all a little bit introvert here and there, we don't like going out, but this really forces you to go talk to people to know whether or not your product is viable in the market. So the I-Corps, what it does is it uses the standard scientific method, right? We all know that as scientists and engineers, we create a hypothesis, we test it, and then we validate it. I-Corps does the exact same thing. However, this is applied to the business. So what it does is that you have a starting hypothesis. So for us, something like the PRIM, we want to say pregnant women want our prediction tool that they can use, and they would pay for it. I-Corps says, now get out and go test it. Put your products aside just for a little bit and go test it. Talk to mothers, talk to women, talk to OBs, talk to hospital administrators, and talk to the best people of all, insurance providers. Because these people will end up paying for it. You laugh now, I did too. But this was something that we found out, and as we'll go through this, I'll kind of get into a little bit more. But what you'll actually find out is that initial hypothesis that I created, like I said, women are our customers, is usually wrong. Everybody finds this out either in the first week or in the 5th week. But this is something that I-Corps wants you to understand and then progress from there. So this is all part of the process. So why the I-Corps? I told you what it was, but why is it actually important? So I don't know if you've heard about something called the Valley of Death, but it's this transition period between going from a lab research project or a lab research system into a commercial system. The gap between this, a lot of products will fall in and eventually will never make it to the people that you originally designed your product to serve. Why? Because you have this lab research, you get grants, you publish papers, students graduate, and what happens when you graduate? Sometimes the funding runs out for that specific project and then the lab moves on. It never really reaches the hands of the people who you're trying to design this for. And that's why I-Corps is there. It forces you to go out, talk to people, and has their verified scientific process that you're going to talk, find a commercial pathway that's not just a theory, but through direct conversations with the people, you would actually know who is going to use your product, not who you're helping, who's going to use the product, and more importantly, who's going to pay for it. We'd all love free stuff, right? New technology, free stuff. Everybody would use it, but will you pay for it? That's the big question, especially in the business world. And that's something that we never really understood until we got introduced to this process. So what is the process, right? We built a team. We had help from Startup FIU. We went through this rigorous training over a couple of days. We understood what the business process and what this something called Business Model Canvas really is. And then we applied for the regional I-Corps. So this is a shorter 1-week program. We have 15 interviews. And then the national I-Corps, which is 100 interviews over 7 weeks, right? Where we have to talk and understand what's really happening in our entire customer ecosystem. Now they provide $50,000 for travel and customer discovery, and then you still have to attend all of these different classes that they provide 2 to 3 times a week. Now just to note that this program used to be in person for the start and the end. They take you to the cohort, and it gives you a really full immersive experience, but once we had COVID, it became all online. Yes?
Can I interrupt you?
Yes,
So
of course.
who finds those 100?
We do.
We do.
And
We
how
do.
do you do? Like, how do you even?
Perfect.
Your
So-
whole network.
So if we knew you before and were very familiar, we would have called you and be like, do you have anyone or clinical collaborators who we can talk to? So we really just, we were quite fortunate enough that in this process, which I'll get to in the next slide, is that we were able to use the $50,000 to travel all over the country, including Canada, as well as Canada, sorry.
The best.
As well as Canada, with our team to interview these people. They prefer in-person interviews because a phone call or a Zoom call, you really don't get the personal interactions. Now, I said that what I-Corps wanted was to put your product aside for a moment and find your market. So for us, it might be slightly different that we knew we had a case and we knew that we needed, this advice was needed, but we still were able to take all this information to get the product where it needed to go. And that's the key lessons from here. So, thank you for the question. How do we find these people? We had a lot of conferences that we went to, and imagine this, 2 PhD students flying around in 7 weeks to all these different places, just trying to get 15 to 30-minute conversations for people that are mothers that care about the femtech industry, other entrepreneurs. So these end up being your competitors or kind of your collaborators, as well as different hospital administrators, insurance agents. So it's a wide ecosystem. So it's not just, we built this device to save lives, obviously. Everybody wants to do that. We built this device for women, for maternal health, yes. But how do we get it to them? And that's the answer that we're looking for in order to be able to commercialize such a product from the lab to the industry. Next. So a little bit into what the I-Corps makes you do. So this is our favorite thing, homework. We have homework over the course of the 7 weeks. This is the business model canvas. All right, so the business model canvas highlights 9 key fundamentals in developing and having a business take off. So something that I want to highlight here is the value proposition and customer segment. These are all interlinked. So you have to know what value serves what customer. And another example is that what revenue streams support your costs. These are not things that we think about when we're developing technologies in the lab. We just want it to work. Right? We want to publish papers, we want to get recognized for our work, but we want the basic science to work. I understand what's going on. Now this is everything else that you see in a hospital once you get there. So this is how you can get your hands into the right people. This is an example of our business model canvas at the end. So if you've seen a business model canvas before and you see this and you're like, oh, that looks so clean, thank you very much. But if you haven't seen one before and it looks terrible, we had something 3 or 4 pages longer. Right? So this business model canvas really shows that if you have gaps in your understanding of where your product fits in the market, it's completely highlighted, where you can't connect some of these boxes that are supposed to be basically interlinked. Right? And then I don't want to get into too much detail right now, but I want to highlight something that I put up as my pretend hypothesis. We wanted our customers to be women. So if I said that before, and that was the first thing they asked, who's your customer? I said, pregnant woman. This is who we're trying to serve. No. They shot me down for about 2 weeks because we couldn't get the answer we wanted. Eventually, we came down to this. Our main customer is chief OBGYNs and level 1 research hospitals. So level 1 is Jackson in Miami, in our case. And, and you think, if you're saying that, I understand why chief OB is awesome. But if you don't, that's even better because Jenny's gonna get into it in a few slides.
Yes. So now let's talk about the outcome of our I-Core market research. It begins with the identification of the market opportunities, which for us is the femtech industry, products and services specifically targeted for female health. And that's currently valued at around $75 billion by 2033. Then our serviceable addressable market is the fetal monitoring system, and that is valued at about $5.2 billion globally. But of course, the actual market that we're able to tap into is the US fetal monitoring system, and that's valued about $800 billion. One of the most important lessons from our NSF I-Core was that the distribution infrastructure we needed already exists. We don't have to build it. Let me walk you through the commercial relationships built from the slide. For customer acquisition and relationship building, the Society for Maternal Fetal Medicine annual meeting is the most important conference in our target market. This is where the MFM specialists, the exact clinicians who manage high-risk pregnancies and who would prescribe PRIM, gather every year. We already presented at SMFM, and we have a relationship there. That channel is open. For therapeutic partnerships, we've identified natural complementary relationships with companies like Preterm, which offers a maternal blood test for preterm birth risk, and Novacuff, which makes a preterm intervention device. These aren't direct competitors, they're just adjacent diagnostic and intervention tools addressing the same clinical problem from different angles. Partnerships or co-marketing arrangements are realistic. For distribution, companies like Probo Medical and Madrid are established medical equipment distributors with existing hospital relationship logistics, infrastructure, and sales forces that call on OBGYN departments. They distribute capital equipment and disposables. PRIM, a handheld device with a reoccurring disposable sheet, fit directly into their product portfolio. The key lesson here is that building a medtech company doesn't mean building everything from scratch. It means finding where your product fits into the existing ecosystem and plugging it in strategically. Next, our current competitive landscape is the current standard of care for preterm birth risk assessment, which involves 3 tools: digital cervical examination, transvaginal ultrasound for cervical length measurement, and the fetal fibronectin testing. The digital cervical exam is where a trained clinician uses their fingers to assess cervical dilation, effacement, and consistency. It's entirely subjective and it varies between providers, and it requires physical access. And it detects risk only after the cervix has already substantially remodeled. The cost per assessment is around $150, primarily as the professional fee. It offers no early detection and no objective measurement. Transvaginal ultrasound, more objective, it gives you a cervical length in millimeters, but it only becomes informative once the cervix has shortened below a threshold of about 25 millimeters, which is in itself a late stage indicator. It also intervenes by definition, requires specialized equipment and training, and costs around $120 per exam. It's useful, but it's a late stage warning system that's not an early stage. Fetal fibronectin is a biochemical swab test that detects a protein associated with membrane disruption. Its binary positive or negative test results has a high false positive rate and limits positive predictive value. And it's most informative only at the 22 to 34 week window, and at $225 per test, it's also the most expensive option, and it provides no structural information about the cervix. The PRIM is objective, non-invasive, early detection, and the capability is from the first trimester. $25 per scan, it's usable in rural areas or lower resource settings without requiring a specialist, and designed for longitudinal use across many visits. The positioning map, The positioning map here is a useful way to visualize where PRIM sits relative to the competition and why the competitive position is unique, genuinely unique. The horizontal axis runs from subjective to accurate. The vertical axis runs from late detection to early detection, and ideally, you want to be in the upper right, accurate and early. As you can see, our competition is not able to reach that. And so we have found that we actually don't really have a direct competitor, and we are currently creating our own category of objective portable cervical diagnostics. So I want to spend a moment on the slide because it represents something philosophically important about this technology, how this technology came to exist. The clinical need for objective cervical remodeling is not new. Obstetricians have been asking for a tool like this for decades. The scientific community has known that cervical collagen remodeling precedes perforation, but the gap between the biology knowledge and the clinical measurement tool has been sitting there, openly acknowledged for a very long time. What wasn't available was the right combination of optical physics, tissue biology, and engineering to bridge it. Mueller matrix polarimetry as a practical imaging modality miniaturizes into a handheld form factor with analytical framework to extract clinically meaningful biomarkers. That combination did not exist. The question of where to deploy the PRIM first is not just a commercial question, it's a scientific and strategic one. Our initial target is a level 1 research hospital, and let me explain why that is the proper entry point. Level 1 research hospitals have several characteristics that make them ideal for the first deployment. They have the highest risk patient populations, women with prior preterm birth rates, short cervix, multiple gestations, uterine abnormalities, exactly the patients where a preterm birth prediction tool has the highest clinical utility. They have biostatistics infrastructure, IRB infrastructure, and research coordinators who can run a rigorous longitudinal cohort study. They have NICUs to document neonatal outcomes, which closely loop between our cervical measurement and the clinical endpoint we're trying to predict. And they have a reimbursement relationship with payers that are more sophisticated and more willing to engage with novel diagnostic codes. Our primary clinical collaborator for this initial deployment is Dr. Michael Paidis, the professor and chair of OBGYN and reproductive sciences at the University of Miami Miller School of Medicine and chief of service at Jackson Health Systems. Dr. Paidis oversees OBGYN services at Jackson Memorial, the largest public hospital in the United States. He is a co-author on our Mueller Matrix cervical imaging publication, and he manages high-risk pregnancies directly at the maternal fetal medicine specialist. He is both a scientific collaborator and a clinical champion, and in MedTech, having a credible clinical champion at the anchor of, as the anchor institution is often the difference between a device that gets adopted and one that doesn't. The commercialization roadmap will unfold in 3 distinct phases, each building on the last. Phase 1 is about establishing the clinical evidence base. This is where the development of the PRIM is finalized with the hardware and software, followed by a pilot study to confirm safety, usability, and then the IRB-approved clinical study at the Baptist and Jackson Memorial Hospital. Phase 2 is a hospital deployment and expansion to clinic partnerships. Having established clinical evidence in level 1 research hospitals, we move into community and clinics and rural health centers. This is where the equity dimension of this technology becomes concrete. These are the settings where high-risk pregnant women often have the least access to specialized monitoring and where preterm birth rates are often the highest. We're actively working on a clinical partnership framework that makes PRIM accessible in low-resource settings, not just in academic hospitals. Phase 3 is beyond. The vision for home telehealth integration, a compact, consumer-grade version of PRIM used by the patient herself or by the community health worker, transmitting cervical measurements into a real-time clinician's dashboard, continuous remote monitoring throughout pregnancy. So the business model we have created in the I-Core has allowed us to enter the whole prize and win the district competition. We are now heading to nationals in May. What is the whole prize? It's the world's largest student social entrepreneurship competition with over 100,000 participants annually and for more than 500 universities globally. It's backed by the Holt International Business School and the Clinton Global Initiative with a grand prize of $1 million in seed funding for the winning social venture. The competition explicitly challenges teams to build sustainable business solutions for the United Nations Sustainable Development Goals. I want to highlight that entering this competition was strategically valuable beyond the prize itself. As the scientific conferences that we attend are environments where you defend your science to other scientists. The evaluation criteria are technical rigor, novelty, reproducibility, and that's a skill we develop extensively in PhD training. The whole prize puts you in a completely different room. You're presenting to business judges, social impact investors, and global health advocates. The question isn't, is your Mueller matrix decomposition mathematically sound? The question is, How many lives does this save? How quickly and at what cost? And why should anyone bet on your team to deliver? So the PolarDoc team that competed is presented here. We have myself, the CEO, which leading the commercial strategy, as the I-Core Commercial Digital Discovery gave me a lot of knowledge in this field. We have Amanda Sanchez, who was the CTO, bridging the optical science and engineering implementation, translating what the SAM and the TRIM do in a portable, manufacturable, FDA sustainable device that is non-trivial engineering problem, and having someone who understands both physics and engineering constraints in that role is essential. We have our CMO, Chief Manufacturing Officer, Abiel Masayo-Ruiz, who focuses on the manufacturing pathway. Our advisors are, of course, Dr. Jessica Romella-Roman, who provides a scientific and technical anchor. Dr. Nola Holness, a nurse practitioner and professor of nursing, bringing a dimension that is easy to underestimate, but critically important, the nursing and midwifery ecosystem. The majority of the prenatal care touchpoints are with the nurses and midwives, not physicians. And then finally, our strategic advisor, Michael Azuki, bringing the business development and commercialization experience that bridges academic technology transfer and industry partnership.
Right. That was a lot. Trust me, I understand. But remember, these things that we found out were done in 7 weeks. We had to come up with an end product for the NSF I-Core to prove that to show that their $50,000 went somewhere for our product, and all of these information was gathered in that 7 weeks. Just let that sit in for a minute, right? So, however, if you are one of those teams that may not really see that your product has a good fit in the market, it doesn't mean that your product is worthless, right? So the idea is that the I-Core has this iterative process so that you can go back to the drawing board, maybe design, build, and test to really find what your consumer base is looking for based on the I-Core feedback. So this is a process that you can then continue, right? However, if you do find that you have the magic product, the magic pill, or the perfect system, there are pathways to licensing directly from the university and with any investors that you may find along the way. Although this is not a typical path, as you will still continue to have this need for R&D and need for funding in order to get your product to become what's called a minimum viable product for the market. And then with this, we have this startup phase where we build a startup in order to eventually apply for this SBIR, STTR, which I'll go into later on. However, it requires the collaboration with some sort of company. And so this is the startup that was developed and owned by Dr. Jessica Romella. And we are PolarRed, bringing these optical solutions for you, where we bring up these engineered optical solutions to have different characterization for properties, simulation-driven design, a lot of different bench testing capabilities, as well as diagnostic products that come out of the MPL FIU lab. So SBIR, STTR, this is that final phase of funding that that you want to achieve in order to push your product into the marketplace. So what is SBIR and STTR? SBIR stands for Small Business Innovation Research. STTR stands for Small Business Technology Transfer. And these are two governmental pathways that fund a lot of these small companies that are just starting out from the university level, trying to get a commercially viable product. So some key difference is that SBIR doesn't actually require a university collaboration. You can apply for it through a company that just has to be considered small business, so less than 500 employees. And however, the PI must be part of that company if you have a collaborator. Whereas STTR is designed specifically for collaboration between university and company, and your PI has to be part of the institution. So this is just the funding phase, looking at how much money you're going to get for each phase of these grants, SBIR, STTR, where the first phase is feasibility. They give you 6 to 12 months and money from $50,000 to $275,000, where the funding and the work in the SBIR has to be more oriented towards the company, whereas STTR, you have a little bit more flexibility, and with collaboration, it can come up to 50-50 between the company and institution. Our second phase 2 SBIR really focuses on the research and development. Now they know that you have a product that has high potential to go into the market. You continue the application into phase 2, where you have up to almost $2 million in 2 years to use this funding. And then in phase 3, there's no direct governmental funding. However, by this point, it would assume that you have enough of a viable product that you attract other investors, and then you can move on from there. So some important dates to keep in mind that this is a three-phase cycle throughout the year. So these are the dates that you want to plan as milestones to be able to submit to these in order to get this funding as your product gets closer and closer to being able to be deployed in the market. So something that I believe appeared a bit more recently is that all of these SBIR, STDR applications requires a project pitch before you can even submit a full application. So what does the pitch need? It's just a summary of how your work is related to each of the institution or to whatever agency and institution you're applying to. It scans for the feasibility of your product, but then also once they review it, which only takes a couple of weeks, they'll give you either an invitation to submit a full application or a rejection where you can still resubmit again after reevaluating your submissions. So these are just the agencies in the US that sponsor or that fund SBIR, STDR. As you can see, it goes all the way from health to defense, energy, and even transportation. So what we want to look at here is that they weigh criteria for scientific merit as well as your commercial pathway. So we have this note down here that the I-Corps is highly recommended, and we also know what highly recommended means, right? And it means that they know that it supports the strength that your product has a market that is going to be created and going to. So for us in biomedical engineering, we usually focus on NIH versus NSF, and you want to really read the guidelines before you submit to these SBIR or STDR, because some focus more on the innovation pathways and others focus more on the social impact or the impact of your system. So I just want to sum up this entire process for you in a couple key lessons. Right? Remember, I brought up the idea of who is our customer. Pregnant women are not our customer. They're just the general population. So the chief OBs were our customer. And this specificity is very critical when you have a product like this that you're trying to deploy. Because who you're trying to serve and who's actually going to use your device can be very different people. And last of all, again, payment. Who's going to pay for these systems? We did say print costs $25 per scan. We are able to pay that, yes. But the device itself, if you want this at home, or I want to say pregnant women who XYZ are my patient, they're not going to pay $10,000 or $5,000 even for a device like this. That's how much it costs to make, just to use for a single for evaluation. Right? That's what that's the feedback that we were getting. So we had to reevaluate the process. And pivoting. Pivoting is not failure. Pivoting is encouraged by the NSF and encouraged by the I-Corps program because it allows us to use our experience to rework our understanding and assumptions to get our product to the market. And next, the ecosystem is vast. Ecosystem is everyone from women, OBs, to hospital administrators, to medical device distributors. You need to understand the pain points for each one to be able to strategically have your product in the market and to have it be effective and get to those who need it most. And lastly, university support exists. Use them. Startup FIU, Tech Transfer Office. They're there and available and to assist you in this process. They have high incentives and they want this to happen. As well as looking at governmental funding pathways. Again, they exist. NSF, as well as the SBIR pathway, have the available funding. And as Dr. Marina has said, the femtech industry is growing, especially for us. So this is where we want to insert our products.
So before we close, we wanted to let you know how you can join us. Thought there would be more undergrads here, but you can join us as students. If you have any information on clinical partners that we might be able to, add to our team, we would love to hear from you. And also, if you're interested in funding, then we have a QR code for you in Kickstarter. So our final message is that every 40 seconds a preterm baby passes away, and so you should help us bring PRIM to every mother. Join Polar Doc, and the PRIM gives every pregnancy the early warning it deserves. Thank you.
as you know, we reached top 50, right? FIU is now top 50, and we have a very ambitious plan to go to top 30 in the next 4 years. So that means that we have to hit some criteria. And in the realms of patents, we are super strong, but we also are extremely well funded. And I don't know if you saw that slide, but when we submit a patent or even a disclosure, we are actually paid. Now, not just API, I'm pushing. The co-investigator. So if you have a good idea, I mean, granted, FIU will own that IP. But if you feel comfortable with that, you can always buy back your right. If you are comfortable with that, that is for you a source of revenue, and the university wants that, right? They want more patents, they want more, right. So, keep that in mind. Now, sorry, questions?
Can you comment on the whole timeline from the, I don't know, did it all start with JBO publication, or how long did it take from a, I guess, idea to the point you're right now at?
It's before
This is
their
before
time.
me.
For us.
Okay, sure, still.
Well, we've been working on women health for about 10 years now.
Okay.
So from the first JBO paper was maybe 8 years ago. And then the ICOR was,
The ICOR was
2 years ago.
2 years ago.
Yeah, and then
we founded the company this year.
and then the development of the device was actually during COVID, right? Our first prototype was COVID. So-
The portable device. I mean, we have a lot of, as you've seen, we have a lot of
And the
instruments.
first patent on this came when?
The first patent was about,
Disclosure application, put it this way, first initial.
the first patent, it was 8 years ago.
Okay, so 2 years after JBO.
So actually, I believe
So that's why you file for disclosure first,
Yeah.
right? The disclosure protects your intellectual property for at least 1 year. And in the meanwhile, you get your patent in, and then you go back and forth until you get your patent. So the IP is actually protected in that sense. The patent was protected before the paper came out. So, but that's a very important point. When you write an article, you don't, or you go to a conference, you don't think about it, but you are kind of, if you didn't file for a provisional, then you shoot yourself in the foot, right? So it's very important to at least file for provisional. And the process is extremely simple here. There's an online platform, right? We actually have here somebody that can speak more about it. We have an online
I'm not
platform.
from Tech Transfer Office, but I'm from Startup FIU. I help faculty and students commercialize the technology. But for Tech Transfer Office, yes, they have a portal in the FIU website. You guys can go ahead and file your ideas in there, just on the form in there. Then they will keep in touch with you throughout your progress on creating a thing.
But the first step is, they're trying, as I said, they're trying to get more patents. And obviously you have to have a viable idea, right? It's not everything goes through clear. But they are trying to make the process very easy, which is not always the case at FIU, so. Any other questions?
For the, you said that FIU is 100% IP, isn't there some kind of, or is it just like a licensing split with guaranteed or something, like in terms of 60/40 was in my head, is that? what
Yeah,
is-
yeah,
how
there
does
is
that
a
work?
licensing.
there's a licensing split. Once you license, you can, you sit there and negotiate with the relevant companies and FIU. But there is a 60/40 split, that number. I saw 40. But yeah, so once you negotiate the licensing agreement with FIU, then you'll be able to take your product. And then Startup FIU was really great about this. Andres and I had a series of conversations with Rob Hacker about this originally. Not Polar. But the reason we're doing this is that if you guys have something, thinking about SBIR is not after you've done 5 years of research. It's, you think about it now, you apply the disclosures now, and as you're doing this process, you know your pathway and how you get through this process. Because not all the I4 teams that, when we were in there, actually had physical products or tangible products sometimes. They would talk about it, but we never actually saw what it was. Because they actually tell you, put your stuff away, put it in a box. 7 weeks later, and then you know, you're back at the engineering phase. But really, you're not supposed to talk to your customers about your product. You want to know what pain points they have, and then in your own mind, you're like, oh, I can solve these in this way, and that's their process, right? And actually, it works pretty well. We learned a lot of stuff.
I also would like to highly recommend, if you have any type of idea, the I-Core process is actually extremely valuable. It kind of added a different layer of understanding in my PhD path, I guess. And I also found that I was able to actually talk to a lot of people who are very passionate in the same field as me, but on the other side. And it really, I don't know, and it really added to this PhD experience. So if you're ever interested in going into industry, I think the I-Core is a really great experience.
All right. Any other questions? I mean, you know where to reach these guys? They're locked in the lab. So, well, thank you very much.